Welcome to the final session of Rio Rhythm Interventions Online 2023. I'm Richard Schilling and I'm speaking to you from One Welbeck, and I'm also based at St Bart's Hospital in London. We have a really important and interesting end to this year's events, and it's particularly pertinent to me as a clinician, as I'm sure it is to all of our audience. One of the challenges that we face as clinicians is how we approach the patient when they can come back after a procedure. And for me, success and absence of complications is really important, because I find it so depressing when I have to face a patient who's had a bad outcome. And so for me, these topics are of great interest. Gaps in care for CIED infection and how to address them, and risk factor modification and AF ablation working together to improve outcomes. These topics are really important because they're often overlooked, and we are still not very good at addressing them in order to give the patients the best possible outcome after their procedures. And so I'm really interested in what our speakers have to say today. First, I want us to meet our panel. Jason Andrade from Vancouver in Canada, Danutar from Oslo in Norway, and Carina Blomström Lundqvist from Uppsala in Sweden. A reminder to you, please do keep submitting your questions for the panel in the blue field on the broadcast platform, because I'm going to try and come to as many of those questions as possible during the discussions and during the intervals after the presentations. We're just about on time, and so what I'm going to do is ask Carina to give her presentation on gaps in care for CIED infection and how to address them. Over to you, Carina.
So thank you. It will be a pleasure for me to discuss the gaps in care for device infection and how to address them. My conflicts of interest. Before going into that topic, I would like to remind you about the increasing rate of device infections during the last 10-15 years, related to older patients with more comorbidities, having more complex systems. And this was reported in the Danish registry publication, reporting that device-related infection incidence during device lifetime was about 1.43%. And here you can see the increasing rate of infections with more complex devices. And if devices are replaced, even higher infection rates. So device infection is common in clinical practice. The overall CIED infection rates is about 6% at 15 years, 12% at 25 years, and even 24% if you have an implant and 2 reimplantations. Major device infections is associated with increased mortality. Here we can see the mortality rate from the index procedure is about 16% at 12 months in infected patients, as compared to 5% in non-infected patients. The mortality rate after onset of infection increases beyond the first 12 months from 16 to 23%. So complete device and lead system removal is a class 1 recommendations for all patients with device infections in all international guidelines. So all of them recommend complete extraction, and 4 of the 5 guidelines published recommend prompt extraction. And that is related to the risk of relapse without complete removal is very high. Infection relapse occurs in 50 to 100% of cases with partial removal or antibiotic treatment alone, as compared to relapse of 0 to 4% with complete system removal. The 1-year survival rate is higher if device is removed as compared if not removed. And you can see here on this Kaplan-Meier curve that the difference is as high as 18%. We also know that timely referral for extraction can be life-saving, and the timing of extraction thus affects outcome. So there is a higher survival in patients extracted early, that is within the first 7 days from diagnosis, as compared if a device is extracted later after 7 days. And this is true both for systemic infections and for pocket infections. Now, the extraction for device infection is associated with a very high procedural success rate. In the majority of patients, it's over 95%. And we should be aware that there is a low major procedural complication rate ranging from 0 to 4%, and that there is a very low procedural mortality rate ranging from 0 to 1%. So what are the gaps in care for CIED infection and how to address them? There is a worldwide survey published by European Heart Rhythm Association, sending out questionnaires to 234 centers, including 62 countries. And as you can see, there was a regional difference in the management of CIED pocket infections without systemic involvement. In almost 40% of responders, no action was taken. And in only 62% was the device completely removed. There is another survey, also a European Heart Rhythm Association survey, sent out to European countries, including 336 physicians of various competence, extractors, cardiologists, non-extractors, and non-cardiologists. And the knowledge gaps or the lack of confidence was quite significant with regard to management of device erosion, management of pocket infection, and also Staph aureus bacteremia without infective endocarditis. So what does the world real data tell us? This is a study from the Duke Center of lead extraction and mortality among patients with device infections. They included patients from the medical beneficiaries from January 2006 to 2019. Over 1 million patients with devices were included, and 1.1% had a device infection. Of these infected patients, only 18.1% were actually extracted within 12 months. They also show that any extraction associated with lower mortality versus no extraction, hazard ratio 0.82. And extraction within 6 days had a lower mortality versus not extracted within 6 days. So out of the million patients, there were 1.1% with infections. 81% of the patients were not extracted, and this was associated with a mortality rate of 32%. 5% were extracted between days 7 and 30. 23% died. Only 30% underwent extraction within 6 days of diagnosis, according to the guidelines. And this was associated with an 18.5 1-year mortality. So in over 8 of 10 patients are not treated according to class 1 guidelines for device infection, and 43% lower risk of death with timely system extraction versus no extraction. And it should be emphasized that female and Black patients were less likely to undergo extraction. So there is a low rate of guideline-directed care associated with higher mortality in patients with infected CIEDs. So what are the gaps in care for the device infection and how should we address them? This is again the same ERA survey that we presented just recently, and they looked into the three main barriers in device infection management. And these were identification barriers, prompt referral barriers, and extraction barriers. Identification barriers included lack of knowledge or skills to diagnose and refer for lead extraction. Over 50% of the non-extraction doctors felt this was a barrier. Prompt referral barriers included proximity to extraction center, ease of access to extraction center, fear of losing the patient to the extraction center, and other factors were bed constraints, cost, perceived lack of diagnosis. If we look at the extraction barriers, we have factors like patient comorbidities, age of patients, age of lead, and a perceived high risk of procedural mortality, which we heard is not a high risk, perceived difficulty of the procedure. So to conclude on how to address the gaps in knowledge skills, I think it's important to increase the awareness of risk factors to prevent device infections, provide more education with prevention, and to educate both physicians and patients at all levels to detect and diagnose device infections better, to refer patients in time, and to proceed with complete system removal in time. Thank you very much for your attention.
Well, thanks very much, Karina. That was really fascinating and somewhat shocking, really, that the gap between appropriate care and the reality is so big, and particularly in women and ethnic minorities. I wanted just to ask you first, before I come on to the panel, is that linked to socioeconomic status? Why is there that gap between the access to extraction if you get an infection if you're Black rather than another ethnic group?
I think there are the factors that I just summarized for you. Hesitancy because people or physicians have the perception that extraction is dangerous. It's associated with a high mortality, but it's not. It's only up to 1%. So that is a misperception, actually. I think it may also be a case that if you do not have an extraction center close nearby, there may be an increased cost for smaller hospitals to refer patients. So they start with antibiotics, and then patient worsens, and once the patient is worsened, they do not refer because they think they will not survive. So it's a complex situation.
So I'm going to come back to the very beginning and start by asking you, Dan, how do we stop the device infection occurring in the first place?
Yes, that's of course the main topic that Karina also put forward. Mainly, there are of course a number of detrimental items that we need to be aware of that can very efficiently prevent and affect an infection to occur. And as we have seen, some of these barriers are linked to the preparation of a patient before device implantation. And just to give you one example, I mean, overall, the median age of a pacemaker or ICD or CRT population is very often close to 80 years. And obviously, many of those have an indication either for antiplatelet therapy or anticoagulation. And in that sense, one very important factor to take care of is not to produce a pocket hematoma. So it is very prudent to discontinue in a smart mode the anticoagulation and or antiplatelet therapy ahead of an amputation, just as one of the examples.
Great. And Jason, Karina pointed out that the incidence of infection is greater in box changes than in the de novo implantation, which is slightly counterintuitive because you'd imagine it would be a simpler procedure. I guess we've all postulated on why that might be. Do you have any idea for the audience why that would be the case and how you avoid it?
Yeah, I mean, I think it's, entirely relevant that the risk of de novo infection is actually pretty low and increases with complexity of the patient and the procedure. When it comes to generator changes, I mean, the way I always think about it is that you have a pocket where you have a generator encased in scar tissue. Scar tissue is not vascularized. And so the ability for your systemic antibiotics that you give pre-procedure to percolate into that pocket and prevent the infection from occurring is limited. And so on the first procedure, the tissue is well vascularized. It's vital tissue. It's going to distribute the antibiotics in a very even way to prevent the infection. But on the repeat procedure, you're at much higher risk of introducing a skin organism that's just not going to get affected by the antibiotics that are given. So it just becomes a complicating procedure due to the fact that there's scar. It's not native tissue, and it's not healthy in the way that we would think of it otherwise.
So do you think that my attempts to disrupt the pocket and try and sort of create some vascular tissue there is a sad and failed effort, or is it worth doing?
It may be worth doing. I mean, where we are, we have one implanter who does a capsulectomy every single time there's a generator change. So he basically goes in and removes all of that scar tissue as best he can. I think the downside of doing that is you're running the risk of injuring an old lead and creating a problem there that's going to create more complexity and complications down the road. But for me, on Tuesday, I did a generator change in someone who had a 32-year-old pacemaker lead. And, they were in their 90s. This is someone who's, an infection would be catastrophic. And so, I don't mess with the old leads, but at the same time, this is where we start to think about things like Tyrex and antibacterial pocket washes and augmented therapy as opposed to just our standard prophylactic antibiotics.
So, Karina, we've got quite a lot of input from the audience who are clearly very engaged by this. And one of the questions that they've asked is, have diagnostic advances either minimized the under or over diagnosis of infection?
Could you repeat that question again? Because there is some echo.
So the question from the audience is, have advances in diagnostics made diagnosis either easier or harder? So, for example, I guess PET scanning, has that been helpful in diagnosing endocarditis related to devices and leads?
Yes. Of course, PET scan is one tool that you can use. It's very difficult to detect and to diagnose infection without transesophageal echocardiography. So that is investigation that has to be done if you suspect an infection. And also PET scan, and you have other diagnostic tools that can be used.
So Dan, I want to ask you, this is a question or a challenge that I'm frequently presented with by the infectious endocarditis team. So I've got a patient with a TAVI, they've had a TAVI, they've had a pacemaker, they've now got recurrent infection that they can't get rid of, and the device has been in for some time. There's no superficial infection, and they're saying, well, we need to take out the pacemaker because we can remove the device, but we can't get the TAVI out, and we'll often get the infection clear on the TAVI. How do you deal with that challenge of multiple potential sources?
It's indeed a huge clinical challenge. And one of the mind-blowing things here is, as Karina pointed out so elegantly, the fact that the infections may occur years or even decades after the implantation. But we saw 6% infection at 15 years, 12% infection rate at 25 years. So at the end of the day, this is simply a clinical diagnosis which you have to make based on a number of variables, including infectious parameters and so on. And indeed, in case of doubt, one has to go forward and remove a device. Absolutely.
Yeah. Okay. Yeah. I mean, I would tend to agree with you, although I hate to admit that the device that we've put in has got anything to do with it at all. It's our natural tendency to deny everything and hope that it'll all go away, which Karina has very well pointed out that it won't do. Jason, can I ask you, you mentioned the Tyrex and antibiotic pouch. What's the situation that you would use those in electively to try and avoid infection?
Yeah, so for us, we have sort of two circumstances. In a de novo implant, admittedly, it's not evidence-based, but we use something called the PADET score. So the PADET score came out of the PADET study. It was a post hoc analysis of the results, looking to identify those high-risk patients who may benefit from augmentive therapy. In PADET itself, there was no significant benefit for the high-risk cohort, but we use it just to highlight in a more refined manner beyond what we would say like clinical gestalt to identify who are high risk. And so if the PADET score is elevated, it's an elderly patient with diabetes or on immunosuppressants who's going for a CRT, that's the group where we'll put it in on a new implant. When we're looking at generator changes, typically we weight it more towards the negative outcome associated with an infection. So in someone who's got very old leads, who's dependent on their device, who has other comorbidities where extraction risk may be very high, then we're prophylactically using the Tyrex to prevent there from being a problem down the road. And that's kind of the breakdown of how we use it clinically now.
Yeah, just one of the audience has pointed out that they've seen some papers about how you risk score infection, and Bart's have just published a paper on the blister score, which is a scoring system which we found very useful, which includes age and renal function, which is obviously another risk factor, and how many reoperations, as Karina pointed out. The thing I wanted to ask you, Karina, a controversy that has come up in the UK and probably in other countries around the world is the role of extraction in non-surgical centres. Because your point that you made, that access to extraction is an important factor of whether to keep people get them. And so should we be doing low-risk extractions in non-surgical centres?
That's a difficult question, but I would say that it's very difficult to predict a complication, even though you can say that probably it's not difficult to extract or take out a lead that has only been in there for 1 year. But I would certainly make all extractions at the thoracic surgical department with backup with thoracic surgeons in place, particularly if you have older leads.
Yeah, so I think that's a good point. One can risk stratify, and those that have been in for a short time, it's probably reasonable to take out, but bear in mind the potential risk of a catastrophic problem that you need surgical bailout. I guess the audience is also asking about the importance of vegetation. So Dan, if you see a big vegetation on a lead, at what point do you say, let's go for surgical extraction versus percutaneous? What are the things that make you decide that?
So I think this question is very much linked to the experience and expertise of the extracting team. The more complex an extraction will be, the better it is performed by really high volume, high experienced extraction teams. We basically do not do any surgical extractions because we are lucky that we have this expertise in-house. So I cannot speak on behalf of all the type of institutions around.
And what happens if you have a big vegetation? I mean, my experience is that it just embolizes and it's okay. But do you fear if you see a big vegetation on the lead when you're taking it out percutaneously?
Yes, that's clearly a risk. I agree that would make it a surgical indication. Yeah, according to the size. Yeah.
Okay, great. So have you guys got any other comments you wanted to make about this or any points you wanted to raise before we move on to the next topics?
I think it's important to emphasize the importance of having an experienced implanter, because we know that with increased complication, the risk for infection increases. Like electrodislocation, for example, would increase the infection rate for that patient. So the more complex system, the more experienced implanter.
And Jason, sorry, you were going to say something as well.
Well, so I think everything we've spoken about to date in this session is incredibly important in terms of gaps of care and improving access. The concern I have is actually, what do we do after, right? So if you have a dependent patient with the extraction, what's the minimum time that we can go before we re-implant? Do we have any different strategies for how we re-implant? Have you tried different things to bridge them? And when I say bridging, we use a semi-permanent pacemaker via an IJ, so a permanent pacemaker lead that comes out of the skin attached to a can. And then that allows us a little bit more freedom to, treat them for their systemic infection before re-implanting. But, these dependent patients I find to be the most difficult because of this need to wait long enough that we clear the infection without introducing a high risk for re-implantation. So be interested in your thoughts.
We should not forget leadless spacing.
Well, that's the other one. What I was going to ask, because one of the audience has actually asked that, what's the role of leadless pacing in your exit strategy after infection? Let me maybe ask you, Karina, since you raised that.
Yeah, I think the studies have shown that there is extremely low risk for device infections with a leadless pacemaker. So for high-risk patients, I would absolutely consider that option.
I mean, I guess the challenge is in the younger patient where that leadless pacemaker is going to likely be left behind. It may be something you try and avoid. Is that the case, or do you not worry about age for implantation of leadless?
For very young patients, it might be problematic with leadless pacing because they have to exchange. The batteries do not last that long as with a lead device with leads. So
just to summarize this, this session and actually your presentation, because we've had a few people join a bit later, you made a really important set of points. The first is that access to extraction is poor. People react badly to infection and don't give patients the class 1 indication of extraction. It's even more shocking that women and black patients are less likely to get appropriate care than white males, which is a very upsetting statistic. One of the reasons for failure to extract or failure to access is probably access to extraction services, as well as the presenting physicians' knowledge about how to handle that. And so there's clearly both an education and a service provision issue that we have to deal with around the world to get patients appropriate care. So that's a great session. Thank you very much. Now I think it's time for our second presentation, which is very dear and close to my heart, if you'll excuse the pun, which is risk factor modification AF ablation working together to improve outcomes with Jason. And the reason I'm so keen on this is I'm seeing more and more patients presenting with greater and greater risk factors. And I recognize that they're going to put themselves through a procedure that has some element of risk associated with it and certainly some pain. And I worry that if they're not able to address their risk factors, all that we're doing is pushing the problem down the road. And I'll often talk to patients as though and explain that AF is a set of scales. Sinus rhythm and AF is a set of scales. And when you're born, sinus rhythm is down here and AF is up here. And as you grow older, the risk factors begin to build up and you begin to tip into atrial fibrillation. And that all we're doing when we're eliminating AF with treatments like ablation is tipping the scales back. And if they're not able to modify their risk factors, then they're just going to have AF again in a year or so. I'm sorry, I hope I haven't completely taken all of the topics from your presentation, Jason, but I was just trying to set the scene. But let me pass over to you to give a much more expert view and overview of what risk factor modification we should be doing.
Okay, well, thank you very much. I'm just going to switch windows here. So the topic that I thought I was speaking about was risk factor modification ablation, and really how these two strategies are working together. I'm not going to spend too much time talking about, how risk factors predispose to AFib, nor am I going to talk about, treatment of risk factors in terms of the management of AFib outside of ablation. And so those are incredibly important topics. And this review article from Pathak et al. Really highlights the central role of risk factors and risk factor intervention across the spectrum of care for atrial fibrillation. So we know that risk factors, traditional cardiac risk factors, are predisposing conditions for the substrate that will lead to the development of atrial fibrillation. And so we can think of risk factor modification as primary prevention of atrial fibrillation. Once patients are manifesting atrial fibrillation, we have to intervene upon the risk factors to prevent the progression of atrial fibrillation and the need for further intervention. Today we're talking about those patients who have gotten to the point where we're now considering or performing a catheter ablation procedure. And so it's important to recall, or at least think about the idea that risk factor and catheter ablation are not mutually exclusive. We are not doing an ablation and then ignoring risk factors. They really go together. And so most of the presentation that we're going to walk through today is really focused around how those risk factors influence the procedures we do and the outcomes. This is a review article we wrote several years ago, but it just highlights that all of those traditional cardiovascular risk factors, hypertension, diabetes, tobacco use, alcohol consumption, physical inactivity, increased BMI or obesity, sleep apnea, all of these make the atrial fibrillation worse. So they lead to the development of atrial fibrillation. They worsen the outcome once you have atrial fibrillation. And in most cases, intervening and treating these risk factors to contemporary targets will make things better for our patients. And so the framework I wanted to use was from our Canadian guidelines, just because it's most familiar to me. And so for us, assessment and management of risk factors is one of the three main pillars alongside stroke prevention and the management of atrial fibrillation. And within our guidelines, we have this figure that you see on the left, and I'll come back to that at the end to tie everything back together. But really, the focus is on these risk factors that I've listed on the figure. And so as we consider them individually, I'll take you through a little bit about how they influence the procedure, and then again, how managing them can improve the outcomes for our patients. So thinking about hypertension, hypertension is an abnormality that's going to lead to structural change. So it's going to drive that atrial myopathy. When we do EP procedures for patients with hypertension, we know that we see lower voltage when we assess the health of the myocardium. And there are significantly larger low voltage zones in patients with hypertension compared to patients without hypertension. When we take that clinically, we look at the outcomes and we see that advanced atrial substrate induced by the hypertension does lead to a worse outcome down the road. So there's a greater chance of patients having a failure of the procedure or not responding to the procedure and having more recurrences down the road. The interesting thing in this graph that I'm showing you is, I don't know if you saw it initially, but this is looking at patients who had what was deemed to be a successful procedure. So no recurrences at 12 months. So the axis there is only starting after year 1. And you can see that after year 1, those patients with worse hypertension had a much lower freedom from recurrent arrhythmia. And so focusing on that lifestyle modification and those risk factors is what improves the long-term outcomes for our patients with atrial fibrillation. Another interesting thing is how the comorbidity may actually influence the procedure itself. So this study is basically showing you patients with no hypertension in blue. You can see that those patients with controlled hypertension coming in for their procedure in the red line had a very similar outcome compared to those with no hypertension. And so they're arguing essentially that good management of the risk factor effectively takes away the influence of that risk factor on the outcomes. Those with uncontrolled hypertension in the green line had a much worse outcome. And that, I don't think, is a surprising finding. But knowing that a patient has uncontrolled hypertension may help us as we go through our procedural planning and decide what to do. And so you can see here for that uncontrolled hypertension on the left graph, those patients were more likely to have non-PV triggers. And so PVI alone may not be enough for that group because those low voltage zones may act as a non-PV trigger. And so if you can identify the trigger in those with uncontrolled hypertension, you can then intervene, eliminate the trigger, and bring them back to patients without hypertension. On the right graph, you can see those with uncontrolled hypertension where non-PV trigger elimination wasn't performed had a much worse outcome. So not only does the risk factor change the substrate, it changes the procedure that we may do. And so it does factor into some of our planning and some of our interventions. When we look at physical activity, a similar principle, so baseline cardiorespiratory fitness. So those patients that are most fit in the red line have a much better outcome compared to those who have intermediate or low levels of cardiorespiratory fitness. So where they start tells us prognostic information. But also, if we look at an intervention aiming to improve fitness, so now we're trying to improve that risk factor, you can see that those patients that gained fitness, and so on this scale, it was 2 metabolic equivalents, those patients had a much better outcome compared to those that did not gain fitness. And so not only is it where we start, but there is an opportunity to improve the outcome by intervening and improving fitness and preventing recurrence that way. If we look at obesity, this is looking at different BMI categories, so less than 25 all the way up to greater than 40. And you can see that AF recurrence is essentially very correlated to the degree of increase in BMI category. So those patients who are in the higher BMI categories had a much lower freedom from recurrent arrhythmia at baseline. Importantly, this also speaks to complications. So the green line here is showing you any complication. The blue line is showing you minor complications. The red line is showing you major complications. And you can see that as patients increase their BMI category, there's a much larger or a much greater rate of complication. So not only is the success lower for increasing BMI, but they have a higher risk of adverse outcomes. And so the risk-benefit balance narrows down quite a bit. Similar to what we saw with fitness, if you lost more weight, so if you had a weight loss greater than 10%, you had a much better outcome following a procedure. If you did not if you did not lose that much weight or you gained weight, your outcomes were worse. So again, speaking to the fact that where you start is your baseline risk, that will influence what we see during the procedures and what follows, but it's also an opportunity to identify areas of improvement. And this is something that is also augmentative. If you combine fitness level with weight loss, we can then see an even greater degree of improvement for those that gained fitness categorization and lost weight relative to those who did not lose weight and did not gain fitness over time. Losing weight alone or gaining fitness alone is somewhere in the intermediary. So really the benefit is both together. They offer a synergistic effect. And so if we can get patients to improve their fitness and lose weight, that will be the best circumstance for that risk factor management. Sleep apnea is an interesting one because the information is a little bit less clear. What we do know from this meta-analysis is that if you have sleep apnea, you're at a 31% higher risk of AF recurrence following ablation compared to those who do not have sleep apnea. If you look at patients with sleep apnea not taking CPAP, that risk is even higher. It's about 60% higher compared to those who do not have sleep apnea. But where we start to see a little bit of heterogeneity in the studies, but a fairly consistent, or I guess a more reassuring outcome, is those who have sleep apnea with CPAP, you see that there was no significant difference compared to those that did not have sleep apnea. Again, the studies are somewhat inconsistent in their outcomes, but it suggests that if the risk factor is there and we adequately manage it, we can essentially undo the effect of the risk factor. So sort of similar data to what we saw with hypertension, where if you can control the blood pressure, the outcomes become very similar to people who do not have that risk factor. When it comes to alcohol consumption, a very similar pattern. So those that consume alcohol are at higher risk of recurrence compared to those who do not consume alcohol. The interesting thing here is mechanistically, the more alcohol you consume, the greater the chance that you have low voltage zones or atrial substrate change within the body of the atrium. And the more alcohol that you consume, so whether you're a moderate drinker versus a heavy drinker, the greater the amount of low voltage zones, and therefore the lower the success. And so you see not only a dose response relationship between alcohol consumption and the development of the atrial myopathy or the substrate change, but you see that substrate change then translate out into an adverse clinical outcome. And so again, suggesting that this is a mechanistic insight into why patients develop recurrences. There was a big randomized study regarding alcohol consumption out of the Australian group, so Peter Kissler and his colleagues. And what they showed is that abstinence was better than continued drinking, and that increasing your alcohol consumption had a linear relationship with AF recurrences. And so in those patients who are very high risk of recurrence, alcohol abstinence may be a strategy to prevent them from having that problem. For tobacco consumption, we see similar effects. So after an ablation, if patients who continue to smoke have higher risk of recurrence compared to those who don't, it's postulated that this has to do with a pro-inflammatory effect, though the mechanistic insights are not entirely clear. If you never smoked, you had better outcomes compared to current smokers or former smokers. So it's a little bit harder to know whether alcohol cessation confers the same benefit in the long run compared to the differences that we saw with alcohol consumption versus tobacco. The last area to talk about is diabetes. I'd say the relationship between diabetes and AF recurrence is not as clear as the other ones. In the German ablation registry, there was no increased risk of recurrence or no increased procedural risk in patients who had diabetes compared to non-diabetics. And this was a large study, about 8,000 patients across 50 centers. The interesting thing, though, is that on meta-regression of many studies, less patients overall, so about 1,500 patients, there did seem to be a relationship between hemoglobin A1C level. So again, suggesting that worse diabetic control is going to be associated with worse outcomes, and that those patients with diabetes who are well controlled are likely to have outcomes that are closer to non-diabetics. So on the whole, I think most of the evidence that we've presented suggests that these common cardiovascular risk factors that lead to adverse cardiovascular outcomes also lead to adverse outcomes with relationship to atrial fibrillation recurrence, and that managing those risk factors can improve the outcomes for our patients. And so, Richard very eloquently described how he communicates this messaging to his patients. The way I communicate it to my patients is I use this graph from our Canadian guidelines. And what this graph is sort of highlighting is that the development of atrial fibrillation or the perpetuation of atrial fibrillation is multifactorial. So we have non-modifiable substrate, we have modifiable substrate, and we have AF-induced substrate. And so when I see my patients for that 1-year follow-up, everything's going well, I present this graph and I say, look, there's 3 things that are going to lead to long-term recurrence of your atrial fibrillation. The atrial fibrillation-induced substrate change, or the atrial fibrillation-induced recurrences. That's my job. That's what I've been doing with the catheter ablation procedure. I am focused on that part of your care, and we're doing everything we can to prevent that from happening. The modifiable substrate, so the high blood pressure, the sedentary lifestyle, the increased BMI, the sleep apnea, that's the stuff that the patient needs to focus on. And so working together, they will continue to monitor their blood pressure and will adjust the medications when it's high. They'll focus on losing 10% of their body weight. They'll focus on 30 minutes a day of aerobic exercise. They'll focus on adherence with their CPAP. And if they do all of those things, then that will minimize the chance of the atrial fibrillation coming in down the road. The non-modifiable substrate, like their age, their sex, their genetics, those things can't be changed by anyone. But if we work together, we can tackle, 2/3 of the problem that's leading to atrial fibrillation recurrence. And so within the Canadian guidelines, we created this figure, which just highlights some of the treatment targets for each of those common cardiovascular risk factors. Now, we made this figure in the hopes that it was a simple thing that could be put up in the clinic or handed to the patients just to highlight where we want them to be. And so we want as best adherence as we can with CPAP. We want a 10% weight loss to a BMI of under 27. We want hemoglobin A1Cs to be well controlled. We recommend targeting a blood pressure of less than 130/80, so a bit more aggressive than our Canadian hypertension guidelines. We recommend aerobic exercise to prevent AF recurrence, but we also recommend resistance exercise because we know that AF patients are generally elderly and at risk of fractures. So that's the focus on bone health, as well as flexibility exercise to minimize the risk of falls. We recommend complete abstinence from tobacco products, even though the outcomes there are maybe a little bit less certain for arrhythmia perspectives. But we know that tobacco abstinence is beneficial for other health reasons. And for an alcohol perspective, we're recommending less than 1 standard drink per day. And so I think that comprehensive approach offers the best chance for patients to be free of cardiovascular disease or adverse cardiovascular outcomes, as well as optimize their atrial fibrillation outcomes. So thank you.
Well, that's absolutely brilliant, Jason. And I think there's a lot for us to discuss here. I was really struck by the impact of fitness, which, if I understood your slides correctly, seems to be much greater than the impact of losing weight. Is that correct in terms of your likelihood of successful ablation?
I think it's a bit of both. Like if you look at the combination analysis of Legacy with CardioFit, where they looked at those patients who lost weight versus those patients who improved fitness, the outcomes were very similar. But when you put the two together, that's where you see the dramatic benefit. So those that can lose weight and gain fitness are going to be those patients who have the best outcome compared to the other categories.
Great. So let me pass over to Dan and ask, Dan, what do you think the role of risk factor modifying drugs or specifically weight loss drugs like Ozempic or perhaps dapagliflozin have in the management of AF? Is this something that you would advocate for AF patients?
So you're asking a question that is really, really forward-looking, and you're asking me to look into the crystal ball. We have a brand new study from the American Heart, you remember, Select, in a completely different population, namely heart failure. And it is very conceivable that what we have seen with the weight-losing drug, not drug, but injections, is playing out in the heart failures arena will make a difference also in fibrillation and topic. So we have no data on this, but obviously it is very clear, and Jason's presentation in that sense was excellent. Summarizing all the factors, it is very clear that identification of the substrate is crucial. And when we talk about substrate, as we have seen, it's not only the electrical small currents in the atrium, it is the entire body. That is the substrate, and that is also modifiable. So, it reminds me of the presentation of the RACE study back in 2017, when we finally learned, and Jason really confirmed all that very, very well. We finally learned how much an influence the modification of that entire substrate situation will have on recurrence.
Great. And Karina, I would like to ask you about the role of multidisciplinary teams in an AF clinic. So maybe you can tell us about whether you have a multidisciplinary team in your AF clinic to help patients modify their risk factors, and what you think the ideal clinic should look like for AF patients.
Well, I think it's important to have healthcare staff that can devote time to discuss lifestyle modifications with the patient that the physicians usually do not have time during their outpatient clinic. And that relates to all of these risk factors that was presented in the previous presentation. Weight reduction is a very difficult topic and has to be individualized depending on the type of patient. And of course, you cannot ask a patient that is in his 70s or even older to start exercising in the same way that you can expect a younger patient to do. So you have to individualize and personalize the lifestyle modification.
Great, thank you. Jason, I was fascinated by the fact that risk factors like hypertension seem to promote or make it more likely that there are non-venous triggers that are supporting the atrial fibrillation. And I guess that makes sense because you're stretching the atria, you're putting pressure on non-venous tissue. I have to say that I found it a struggle to identify non-venous triggers. What's your strategy for identifying those non-venous triggers and guiding ablation in patients who have other risk factors?
Yeah, I mean, I would say the vast majority of cases of identifying non-PVE triggers are difficult at best. I mean, for us, we're using a combination of multiple mapping catheters with high-dose isopril infusion protocols, supporting blood pressure pharmacologically as the high-dose isopril goes, repeated cardioversion, and stimulation protocols. And if you do that, some of the studies would say it's, as low as about 8% of patients will have it. So other studies say it can be as high as 40% of patients. So I don't think it's as high as 40%. I think it's lower than that. The problem is that even after you identify them, in a lot of cases, you can't actually eliminate them. And so it's non-PV triggers are not all that easy to do, though I think it needs to be done more routinely than just taking an empiric anatomical approach to PVI. Because when you find them and you can eliminate them, we do know that it's consistently better outcomes for those patients.
So in the UK, tobacco use is becoming rarer and rarer, but we're now seeing an epidemic of vaping, particularly amongst the younger population. Do any of you have a feel for whether vaping has any AF stimulating effects in the same way that tobacco has, or is that not a concern?
So my understanding is that there's limited data, but it seems to have the same stimulating effects.
Okay, so it's something we should be worried about, regardless of how they take their inhaled stimulants then.
Yeah.
So I wanted to finally ask you all, in the UK, the NHS England has now restricted AF ablation to patients who have demonstrated that they're either under a certain weight or have lost a certain amount of weight or reduced their BMI. And if they're above that weight, they're not allowed or entitled to an AF ablation. But I don't believe that they've made any resource allocations to assisting patients to lose weight in the AF setting. Can I ask whether your countries have done anything like that? And if they did, how should a healthcare purchaser address this issue of risk factors? So let me ask with Dan first to comment on this very difficult issue.
Yes, it's difficult indeed, because it's playing into the morality of our physician role. I'm a bit critical to such restrictions, because it's kind of unfair. You know, patients generally are motivated to lose weight. Some succeed and most don't succeed. And punishing those who don't succeed by restricting access to a intervention in a completely different area, namely arrhythmia, I don't think it's the right way to go.
And Karina, how do you think healthcare purchasers should deal with this issue?
We have no such restrictions, and I must say I cannot understand that either, because it's a vicious circle for the patient. The patient cannot exercise related to atrial fibrillation, and then it's difficult also for that reason to lose weight. And I would say that if you're not have a BMI around 35, 40, I think that you will have to personalize and look at the patient per se and make a good conclusion whether to proceed with ablation or not. So it should be a discussion between the physician and the patient.
And Jason, what are your thoughts about how this should be managed?
So for us, we don't have any formal restriction. I can say that for those with extremes of weight, there's a hesitancy to undertake procedures. It's not something that we're, aiming to do just because we want to. The problem is that often there's no alternative. So for us, access to bariatric surgery is very limited. It typically involves a 1 to 2 year process before patients are accepted into the program and finally get their surgery, which means that if their quality of life is severely impaired because of atrial fibrillation, the likelihood of you being able to do something after weight loss is going to be 2-3 years away. And the negative impact of waiting those 2 to 3 years may outweigh the potential increased risk of complication and the increased risk of recurrence for going sooner. So, if it's patients where there's limited alternatives to manage their arrhythmia and they've exhausted pharmacological therapy, and now you're at the point where, the only thing you have to help them improve their quality of life is going to be an AF ablation, then we would go ahead because we don't have any other options. But, we don't work in a healthcare system that says you're a smoker, you can't have an ablation, or you drink too much alcohol, you can't have an ablation. So I don't know why we would apply that to something like weight. It seems an unfair judgment.
Yeah, I must say that I take the same approach as you, in that I would do the risk factor modification and the ablation in parallel, because by the time you've got around to the ablation, it may be too late if you wait for them to lose weight. And I'm also very frank with patients and say, look, if you don't lose weight, you're going to have put yourself through this procedure and you're not going to get any long-term benefit. So if you really don't think you can stop drinking alcohol and stop smoking and losing weight, maybe this isn't the right procedure for you. Maybe you should be thinking about a pacemaker and AV node ablation as an alternative. But I think having an open and honest discussion with the patient and giving them the power to make that decision often makes them feel obviously more in control and maybe motivates them to take control of their own destiny in terms of risk factor modification. I think it's really interesting. Some of the insurers, healthcare insurers in the UK, have attempted to help patients with good behavior. So as setting up video health benefit services, and some insurers give reduced funding for patients that demonstrate that they share their shopping list and they share their activity and steps, and so get reduced insurance rates as a result, which I think is a pretty interesting and cool motivation. So I think that we're coming to the end of this really interesting session. I'm very grateful to you all for giving such interesting insights and also giving us an idea of what's going on not only in our own countries, but in around the world, which has been really interesting. So thanks very much to you, Jason, Karina, and Dan, for joining us and for their fantastic contributions. We are nearing the end of Rio 2023, but before we go, let's take a few moments to reflect on what has been quite a fantastic and extraordinary event. Stay tuned.